Good morning, everybody. Thank you very much for joining this webinar on the path to ending smoking using the new funding. Thank you very much to colleagues at ASH for supporting this opportunity to discuss part of what is going to be, I think, a really pivotal opportunity for us as the public health community to make an impact on the health of the public and on inequalities. My name's Andrew Furber. I'm the Regional Director of Public Health for the North West of England. And on behalf of the regional directors, I lead on addictions, which obviously includes tobacco, and it's in that capacity that I'm chairing today's event. We've got a packed agenda, and I'm going to do my best to keep everybody on time to allow time for questions and answers towards the end. But I'm very grateful to all our speakers today. We've got brilliant speakers lined up this morning to take us through some of the issues. And we'll start by hearing from Corrina and the work that she's been doing with Robyn as public health specialty trainees on placement at ASH, who will be presenting their briefing paper on how we might maximise some of the opportunities that come with this additional funding. Then we'll be hearing from Professor Robert West, who I'm sure needs no introduction. I think we're all very familiar with his excellent work. He'll give us a population perspective on how to support people to stop smoking and increase quit attempts. Then we'll be hearing from Dr. Sharon Cox from UCL, who will give us an inequalities perspective, thinking how we can make sure that the work that we're doing really covers and targets disadvantaged populations and enables us to support the reduction of inequalities. And then last but by no means least, we'll be hearing from Alice Wiseman, Vice President of the Association of Directors of Public Health and the Director of Public Health for both Gateshead and Newcastle, on plans that they have in the North East for using this funding in an effective way. So if we go on to the next slide, which just takes us through some housekeeping, we're asking everybody to keep themselves muted and to turn their video off unless they're presenting. We encourage all attendees to submit questions, which I think you can do via the chat, and I'll facilitate a Q&A session towards the end. Just so that you're aware, this webinar is being recorded. If you have any other issues, then please post in the meeting chat or email that email address there, admin@smokefreeaction.org.uk, and we'll do our best to resolve those issues. If we just go on to the next slide, which just summarises the grant conditions around the additional funding, which is coming the way of the local authorities in England. So it's to invest in stop smoking services and support, and it needs to be in addition to and maintaining the existing spend from the public health grants. And I think you'll have heard from your regional directors that the department is going to take quite a hard line on this, as we have been doing with the drug strategy funding, so colleagues need to be aware of that. It's intended to build capacity to deliver expanded local stop smoking services and support, to build demand for those services, and ultimately, of course, to deliver increases in the number of people setting a quit date and 4-week quit outcomes and reporting associated activity and financial spend. So those are the conditions around the grant. So that's it by way of introduction from me, and I'm going to hand over now to Corrina to take us through the briefing paper that her and Robyn have developed.
Thank you, Andrew. And next slide, Jim, please. So, as Andrew said, I'm here to summarise a briefing paper that Ash has been developing with Directors of Public Health and Humber and North Yorkshire's Centre for Tobacco Control Excellence. The paper has also been reviewed and endorsed by the Association of Directors of Public Health. Thank you to colleagues in Humber and North Yorkshire and the Directors of Public Health that have been involved, and also Robyn too, that has supported me by co-authoring this paper. So the purpose of the paper is really threefold. Firstly, to emphasise the massive opportunities with the proposed legislation and additional funding. Secondly, to outline the evidence base to support all people who smoke to quit. We know that to do this, we need to encourage more people who smoke to attempt to quit more often, in the knowledge that more quit attempts will always lead to more quit success. And lastly, the paper concludes with a set of recommendations for Directors of Public Health and their partners that outline the tobacco control activities that can be actioned, again, to maximise the big opportunities that we have with the legislation and the additional funding. I think it's worth saying from the beginning that there's no conditionality with the funding currently, but it should be recognised that the indicators for success are indeed the quit date set and 4-week quits. Nevertheless, we do want to encourage partners across the system that if evidence-based tobacco control activities are used to build capacity, demand, and increase the number of people who smoke to quit, then the results through these indicators will surely follow too. Next slide, Jim, please. So the briefing paper outlines the different pots of additional funding that accompany the proposed smoke-free generation legislation currently passing through Parliament, and that's shown and summarised on this slide here. The focus, though, throughout the rest of the briefing paper and this presentation is how to maximise opportunities with the additional £70 million of funding for local authorities stop smoking support. And the overall aim of this funding is to help people to stop smoking and increase the number of people engaging with effective interventions to quit smoking. It is clear, though, through the grant letters that have accompanied the funding, that it should not be used for enforcement nor NHS inpatient tobacco dependence services. That being said, new collaborations with the NHS are encouraged and will be needed to drive throughput into services. There is the guidance that also has accompanied the funding, which is a little grayer, around youth vaping, which we know is a big priority for many areas. It should be recognised that there are opportunity costs to funding any activity around youth vaping, and areas should review such activity against its contribution to reducing smoking, which should be the key focus with using the additional funding. There are huge opportunities with this funding and opportunities to use it transformatively to drive up quit attempts and quit success, ultimately to realise the vision of a smoke-free generation. There are opportunities to use the funding across wider geographical areas and direct towards activities that are best delivered across these more super-local or regional geographies. These are activities like mass media, outreach, advocacy, all of which will achieve economies of scale and greater levels of impact. There are other opportunities too, and the current climate around the smoke-free generation offers a platform for national conversations like the ones today with partners across the system. There are also new quitting aids coming, like cytosine, generic versions of varenicline, opportunities to build on existing activities like the long-term plan commitments, and opportunities to collaborate between the NHS and local authorities. But I think most importantly, to build on the massive public support that we know through our surveys that there is for the smoke-free generation, government action on tobacco more generally, and all key tobacco control activities. Next slide, please. So this slide shows our current progress in England towards a smoke-free 2030. We can see from the Cancer Research UK most recent modelling projections that the 5% smoke-free 2030 targets will currently be missed by around 9 years if recent trends continue as they are. There is, though, huge inequality in these projections for the most and least deprived areas. The least deprived areas will reach their targets around and about now, but for the most deprived areas, there will be an inequalities gap and a lag of nearly a quarter of a century, which is really quite stark. Next slide, please, Jim. So we know from this that our progress needs to be quicker, that change is required, and that this change will need to be even greater for the most disadvantaged populations. We know that currently around 37% of people who smoke make a quit attempt each year. To reach targets, this will need to increase to at least 45%. We also know that around 26% of these quit attempts are successful, but this will need to increase to around 30% too. Next slide, Jim, please. So to achieve this change and increase quit attempts and chances of success, we need to support all people who smoke to quit more often by promoting treatment and behavioural support, ideally through the most effective methods of support and through routes that meet the needs and preferences of all smokers. Our approach with support needs to be equitable, and we need to focus on key priority groups who we know have higher concentrations of smokers. And Sharon will focus more on this in her presentation later. Next slide, please. So this is the evidence of what we know around methods of quitting. This is based on Sarah Jackson's work, who is an academic in UCL. She kindly videoed this sort of evidence that's accompanied the briefing paper, so that's available there. Through her work, we know that all routes of support should utilise both effective and feasible quitting methods, and that the most effective quitting methods in real-world conditions are varenicline and vapes. People that use these methods have nearly double the odds of quitting compared with those who don't. This is good news for vapes, as they are the most commonly used method in England, and that's shown on this infographic there in green, and they are also low cost. It's less good news, though, for prescription medications, shown in yellow on the infographic, which are only currently used by around 1 in 20. Worse news still for the gold standard combination of behavioural support and prescription medication, shown in pink, as they are the most effective but currently only used by just over 1% of people. So we know that if we increase access to these evidence-based quit aids, that this will increase chances of quit success and also reduce chances of relapse. Next slide, please. So other tobacco control activities that can drive progress are shown on this slide here. So looking at the first two rows, which represent routes of quit support, we know that nearly half of people who smoke try to quit without support, and that the overwhelming majority do so without formal stop smoking services. So there does need to be a balance really between increasing the demand through formal stop smoking services, offering a diverse range of routes of support for all people who smoke, and also maximising opportunities to get people into a route of support of any kind. And there are 3 recommended pillars of support or routes that should be offered for people. Firstly, specialist support targeted to priority groups who need more of it. Secondly, brief advice and treatment for those needing encouragement and guidance. And lastly, self-support and digital for the majority of people who need basic evidence-based information and guidance. We also need to support people through wider tobacco control activities like communications, enforcement and advocacy. These activities are best delivered across wider geographies to maximise impact on smoking rates. These kinds of activities that are best delivered across wider geographies are also useful for making smoking unappealing or denormalising it, and also for promoting hope and the annual quit attempt. This sort of promotion of hope and the annual quit can also be achieved through expanding very brief advice or to drive up quit attempts. Next slide, please. So to finish with, and our briefing paper finishes with a set of recommendations. So these recommendations are framed and targeted at directors of public health as leaders and their wider colleagues across the system, really framed to maximise the opportunities with the additional funding and to encourage them to use it transformatively to increase quit attempts and ultimately quit success. Last slide, Jim, please. So in the briefing paper, there's a full list of recommendations that are structured under 3 overarching ones. The first of which is really around the strategy, partnership and leadership that is needed to secure transformational change and support many more people who smoke to quit. And that's reflected in key recommendations 1 and 4 here. The second around investing in activity to drive up quit attempts in all communities. And lastly, around increasing quit attempts through stop smoking services, which will drive up knowledge and standards in other settings. And I want to leave you really and close with the message that the proposed smoke-free generation legislation and additional funding present a really exciting opportunity for us all and should be seized. So it's worth spending the time and having the ambition to do something different and transformative with the additional funding, ultimately to realise the vision of ending smoking everywhere for everyone. So thank you.
Thank you, Corrina, really clear. And thank you to colleagues who are posting questions in the chat. That's really good to see that, and some responses as well. But without further ado, Robert, can I hand over to you for a population perspective?
Hi, yes. So I'm just going to present as some thoughts about a structure that you can use specifically for maximising the impact of the sort of funding increases that we're seeing. And this is something I prepared for a London Tobacco Control Alliance, and so some of you will have seen it before, I suspect, but I'll take you through it very briefly, and then I'll make the offer now that if any of you want to follow up with this or want the spreadsheet that I'm going to briefly show you, then I'm very happy to take you through it at some later stage. So if we go to the next slide. The equation is a really simple one, which is, but it's always worth keeping absolutely in mind a sort of laser focus on what we're trying to achieve here, which is an increase in the numbers quitting. In this particular case, we're looking at quitters. So, and you achieve that through in the services, which is only one of the routes, of course. You know, whatever we do, most people will be quitting without going to the services, even if we are incredibly successful. But in terms of maximising the impact of the services, what we're trying to do is to increase the numbers attending and increase the quit rate. So it's numbers attending, quit rate overall, and also in particular priority groups. And sometimes there'll be a trade-off there because generally speaking, in order to achieve a particular quit rate in a priority group, you're going to have to spend more in order to be able to do that, because they will require more support. That, as you've heard, they're not less motivated to quit, and it's not that they don't try to quit as often, it's that they find it harder. Next slide. So when developing then a commissioning strategy for stop smoking services to make best use of this money, I'm sure many of the services are well into this process, if not have actually nearly concluded it or concluded it. But essentially, the first thing you have to do is review your current provision. What is it that you're doing? And match that against a set of standards. The National Centre for Smoking Cessation and Training has provided a really detailed set of standards, which are evidence-based and designed to make sure that the provision that is delivered is likely to maximise quit rates. So you review the current provision, identify potential areas for enhancement, and then have a look down your list of those potential areas and see which ones do you think in your particular area with your particular circumstances are going to be the best option for you. And there's a set of criteria that we've developed at UCL over many years for policies generally relating to behaviour change that might be useful here, and we call them the appease criteria. And the purpose there is to expand people's thinking beyond just simply limited effectiveness, but to all the things that one needs to consider when deciding on a behaviour change intervention policy. There is, first of all, acceptability to key stakeholders. There is the practicability, which is obviously going to be a major issue here, given the timescales, the personnel, the need for training, and so on to get services up to scratch. Obviously, there's effectiveness, and by effectiveness here, we're looking at the overall increase in the number of ex-smokers generated in your local population. That's what you're trying to achieve, not just narrowly effectiveness in terms of, for example, the success rate of the service. Then we've got obviously the crucial issue of budgets, and although it does seem quite a lot of money, and relative to what we've had in recent years, it is quite a lot of money that's being given to the services. Historically, it's not that huge, and compared with a lot of other sort of areas of expenditure, it's relatively limited. So it's not like there's one can afford to waste any of it, but also considering particularly things like media support, mass media support and communications to help to drive people into the services and promote quit attempts, that budget can very quickly be used up. Then we've got to consider the spillover effects. Some of them may be positive, a lot of them may be negative, and we have to consider those. And very importantly, obviously, in the end, we have to consider equity. Whatever our strategy is locally, we want to be making sure that we're working to reduce inequality. So those are the sort of broad criteria. If we go to the next slide. Then what I've done, as I said, is to put together a sort of structured way of approaching this problem in the form of an Excel spreadsheet. And I'm just going to take you through that spreadsheet in just a minute. But the basic principle is that it gives you an opportunity to identify all those activities that you're currently doing, which may be a lot or it may be a little, and then go through next step, identifying candidates for enhancement, which either may be starting a whole new activity that you weren't doing, or some enhancement of an existing activity. And then the next step is to go through that, see to what extent each of those meets the appease criteria, so that you can sort of prioritize how you then going to go forward. So I'm going to share my screen now and take you through this spreadsheet. So you should be able to see, hopefully, someone will let me know, I'm sure if you can't, the spreadsheet, and I'll just sort of scroll down. On the left-hand side here is a list of all the various different activities that a local stop smoking program might undertake. And I've started to sort of pre-fill some of the columns to the right here, and I'll just scroll to the right here to see to take it all the way through to the last stage. But this is the first stage here, is where you just say, well, okay, well, what are we currently doing? And on the spreadsheet, if you click on it, it gives you a drop-down list, and you can then select from that list. So things like contributing to a regional programme. Personally, I think this is incredibly important. And in fact, I think there's good evidence that where there are good regional programmes that we've seen in the north east and the northwest, for example, it has made a substantial difference. And apart from anything else, you get really important economies of scale. But more than that, I think it drives up quality. And that's done typically through some sort of top slicing. Sometimes you might contribute through other local authorities, for example, through the integrated care organisations, or whatever they're called. I can't remember the exact name, but you know what I mean. So where they combine together, or you might just combine locally with, so this is what you're currently doing. And then we've got the sort of the meat of the thing. Do you have an in-house specialist service that's available to all smokers? And then there's various options here. You can say, well, okay, we do it directly, or we do it with another local authority. We do it at ICB, Integrated Care Board. That's what I was looking for, or through regional programs and so on. Do you have one for priority groups? Do you have an in-house low intensity service for smokers, etc., etc.? And then the same thing, but basically with contracted out services. Do you have a pharmacy service, GP advice? Do you actually, with GP advice, do you do it sort of as a funded exercise, or is it something that you just hope is going to happen? Do you have your own digital application, or do you buy a digital application, or recommend users to use one? Telephone service, SMS text messaging. These are all evidence-based interventions or parts of the treatment program, although not necessarily all with the same level of effectiveness, but potentially different reach as well. And then when it comes to the medications, you've got all these various different options here. And cytosine was mentioned, which is now available, which I think is potentially incredibly useful, has very similar efficacy to varenicline, and also varenicline may be coming back in generic form. So that would be good news for everyone. And then we've got the vape options. And then we've got things that can help to increase footfall, like primary care outreach, outreach to communities, workplaces, etc., liaison with secondary care. You can see it's quite a comprehensive list. And then we've got the marketing through different channels, owned media, earned media, and above the line or paid marketing, websites, and so on. And then really importantly, potentially, and often not perhaps resourced enough, is staff training and supervision. That we do have evidence that where you have effective training, it boosts success rates. So you go down that, then you say, okay, well, which of these do we think are ones that we want to enhance in this column here? Then you go ahead and say, okay, what kind of enhancement do we want? And it's really just a way of structuring or thinking about this. And then finally, have some discussion and an analysis to help you choose which of the things you're going to focus on as your priority. So I shall stop sharing there. And so with that spreadsheet, and you can adapt that spreadsheet to your own particular needs. It's it's just an editable. It's just a start really for you. But the key things I just want to finish with then are absolutely being laser focused on the extent to which whatever it is you're proposing has a clear evidence-based link, what we would call a logic model in public health terms, which takes you from what it is you're trying to do to the number of ex-smokers that you're going to create with it, so that you're very clear on that. Try and make use of existing resources and provision as far as possible. For example, don't spend a lot of money and time building new digital offerings if there are ones already available. Make use of economies of scale, particularly regional programs are incredibly helpful and important. And just remembering that the priority groups are not less motivated to quit. They don't need more persuasion, they need more help. And then finally, engage with the evidence based on what works best. And there is a huge evidence base, and it's growing all the time. And just keep paying attention to that. And the NCSCT is very good at keeping people up to date. And that's it.
Wonderful, thank you, Robert, and a number of positive comments in the chat there about the tool. People looking forward to using that. Moving on, just keeping around the time, Dr. Sharon Cox, over to you to help us think through inequalities.
Yeah, great. Thanks for having me. So I'm going to talk about supporting smokers to stop and looking at the priority groups. So next slide, please. Okay, so this is something that we're all familiar with. We've seen a decrease in smoking prevalence in England and as well in Scotland and Wales, and we're making really good progress. And we know some of the things that at a population level, as shown here on the left, like plain packaging, raising the age of sale, etc., have all really worked to drive down smoking rates. So that's the good news. Next slide. And traditionally, we've measured inequalities through the toolkit and other measures as well, looking at social grade as measured through occupational social grade. And again, the good news is that across the social gradient, we see smoking rates are coming down. That's a good thing. But there's still this disparity that smoking rates are twice as high amongst people in less advantaged social grades. So people that are usually in routine and manual and therefore often, not always, but often in lower paid work. But we need to get a bit better at how we measure inequalities, and there's some other proxy measures which help us to understand both health and social inequalities, and help us to understand the context of people's lives and why they might, as Robert said, be not being able to sustain a quit attempt. Next slide, please. So housing status is one of the key markers now for deprivation. We're in a housing crisis in the UK, and the numbers of people post-COVID who are accessing or trying to access social housing has risen dramatically. And the number of people that are being pushed into homelessness is also growing. I'm often told these groups, they're really small groups, but they're not. They're growing, and that's a problem. And overwhelmingly, people in these groups smoke. So if we look at people in social housing, this paper is by Sarah Jackson and another paper by Emma Beard from our group. We see that the being in social housing is one of the strongest independent of other predictors of smoking status at around 35%. So if you have finite resources, working with social housing organisations is a really good place to start. Staff there are often based in charities. They want to be upskilled. They want to offer support. So we need to be reaching out to them. Next slide, please. And one of the ways that we can look at other areas of health inequalities and to understand that people who are smoking are not just smoking, they're actually engaging in other types of behaviours which have an exacerbating effect on their health is alcohol. So this paper led by Claire Garnett and our group, well, she's in Bristol now, but was in our group at the time, we wanted to look at, does smoking prevalence rise as potential problems with alcohol rise? And we found that. So what we've done here, and this is a beautiful, although scary, linear curve, that as people's risk of alcohol dependence as measured by the audit went up, so did smoking prevalence, to the point where people who are at risk of alcohol dependence, their smoking prevalence rate was around 57%, and past year smoking was 63%. So again, as Robert highlighted and Corrina, there are groups of people who want to quit, but they're not sustaining those attempts. And it's because they've got other things, other challenges going on in their lives. And actually, what we are finding with smoking, and I can't talk about this all today, is that smoking is often clinically overshadowed by other health and social needs, such as if someone's drinking or taking drugs, then people might think, well, smoking, it's their last pleasure. They've got these other things that they need to address. We did find in this study, though, that people are making as many quit attempts and are accessing evidence-based support, but they're not sustaining them. Next slide, please. So this is an area that I'm really passionate about, and that's inclusion health groups. So this is people that are socially excluded. They are normally excluded from mainstream healthcare, although they have an over-reliance or use on emergency care, which means that although people in inclusion health groups, such as those who use opioids, those people who are experiencing homelessness, vulnerable migrants, they're small groups, but actually in terms of healthcare costs, the the costs are enormous, and their tobacco use really does exacerbate their vulnerability, because they're much more likely to share cigarettes, pick up discarded cigarettes, beg for cigarettes, but also it aggravates other illnesses that they have, such as, for example, maybe TB or other respiratory illnesses. And one of the things we really need to start doing is recording smoking in these groups routinely. We cannot target resources unless we know where our smokers are. So this is some crude plotting here that we've done with my colleague Dan Luer and Harry Tatton-Birch, where we've looked at smoking rates in inclusion health groups from various sources over the years. And it's gone from 90% to about 70%. Now, they're different sources, so we don't know how reliable that is. But if this is a true reflection that smoking has come down in these groups, that's a good thing, considering we've done very little. These groups have not really received any type of targeted support for their smoking. Next slide. This has already been mentioned, but if we don't target these groups, if we don't start to think about how we can directly support people who access different types of healthcare services to quit smoking, then we're going to see this enormous gap in securing the smoke-free goal. This is for people with and without mental health conditions. You can see there's a 20-year gap, but for people in inclusion health groups, we've done some very crude modelling, but it's about 70 to 100 years. Next slide, please. So reasons why quitting are harder for people in this group. If you could, I've got an animation here, so if you can press that, that would be great. So the ones I've highlighted here are the ones that are maybe slightly different. So, all smokers experience the ones above, but for some people, their ability to cope with withdrawal within their current lived environment is really difficult. Next one, please. Yeah, sorry about that. Boredom as well. Smoking for so many people marks time. If you're not in work or you're living in social housing, it can be a way to communicate with people. It can be a way to socialise. But one of the key things we see is that they're just not being offered enough support, and they're not really being given the opportunity to quit. Next slide. And Robert's already mentioned this, but we do see, and this is where the social injustice element is, if you like, that they are trying to quit. So this is just some of the papers, although I could put about another 20 up, that shows that people in these groups across all these different markers of deprivation are making as many quit attempts. Next slide. So there's motivated to quit. They're making as many past year quit attempts as people without such health and social needs. We see some good use of evidence-based support, but lack of sustained attempts. Next slide. So one of the things that people say to me is these groups are really hard to reach. And I've got this Field of Dreams slide. I don't know if you remember this film or get this reference, but it's where Kevin Costner is told by, I think it's Morgan Freeman, that if you build it, they will come, and builds this big baseball stadium in his back garden. And one of the key ways that you can, the point I'm trying to make here is, one of the key things that you can do is, if you offer people support at a place at which they're already accessing, and that's really the key message I want you to take home, is where they're already accessing, they will take up the offer. Now, they will need more support to quit, and that's where we need the evidence on what is this more support and what does that support look like. But they are not hard to reach, and we've got to stop using that term. This is a study here that we've just finished, where we recruited 477 people across 32 homeless centres to take part in our trial. The data will be ready later this year. But the point is, 477 people accessing homeless support services who would probably never have been spoken to about their smoking did sign up and did take part. Next slide, and I'm going to finish. So one of the things that you have to do, and if you look at the slides after, these are some of the things, but you need to take it to a place where people are already at. They don't have the time to be able to go to new appointments. And when we talk about hard to reach, I think we mean that they're not coming into the stop smoking service. So if we can take it to a place where people are already accessing, and Swap to Stop should be able to help with this, and then use these other broader harm reduction methods, then you should be able to recruit people. And I'll end there.
Wonderful. Thank you so much, Sharon. Moving on quickly, Alice, thank you for joining us today to give us a perspective from both ADPH and as a Director of Public Health.
Thank you, Andrew. I nearly couldn't get off camera there, so it's really great to be here. And I guess I'm just going to start off by saying I'm here as Vice President of ADPH, but also Director of Public Health now across Gateshead and Newcastle. But I'm also here as a daughter of my wonderful dad, who sadly died as a result of smoking-related disease at the age of just 54. So I think remembering that each time we are supporting each person to have that critical intent is so important, that it is not just that individual, it is the impact that it has on wider family. And I'm sure many of people on the call today will share that that sentiment. I think I'll just go back a little bit as well, as history shows us that smoking prevalence does not continue to decline without concerted action. You know, in the late 1990s, there were stop smoking services and media campaigns, and we saw some real great reductions in smoking prevalence. But by the time it came to around the mid-2000s, there was some stalling progress, certainly in the North East. And in response to this, we came together as a North East, as 12 local authorities at the time, PCTs, and to look at actually what we could do to tackle this as an issue. And I am really proud to say that we have had our wonderful regional collaboration through our Tobacco Control Office, Fresh, since 2005, that has done much of the work across the North East and certainly made a significant impact in terms of mass media advocacy, coordination, data, insights. I could go on, you know, but actually that coming together, and we've managed to sustain it for the last, you know, almost 20 years now. And I feel really proud to be part of that as a journey. You know, when we started Fresh in 2005, the smoking prevalence in the North East was around, or Gateshead was around 33%. And I look now at the smoking prevalence in Gateshead, and whilst we've still got much work to do, and we are grateful for this additional resourcing, we're down to just over 14%. You know, so some real significant strides, but definitely as a result of that regional collaboration. Next slide, please. So obviously, you know, we've been looking at this, and, you know, we've again seen impacts in terms of the number of people who've been accessing our stop smoking services has been declining year on year. You know, so in the North East, this translates from 63,000 quit attempts in our stop smoking services down to just over 12,000 in 22-23. Now, some of this is obviously attributable to a reduction in smoking prevalence, but actually not all of it. And we know that we need to do work across the patch, and certainly in Gateshead, to try and make sure that our services are accessible to those who need us most. And again, we've heard Sharon talk really eloquently about issues around inequality, and that is certainly something that I see locally in Gateshead. Next slide, please. So across the North East, you know, this is the most amazing opportunity to really end smoking for the next generations. You know, with this additional £3.6 million in funding, and, you know, our decisions at a local level are being driven by the paper that you've heard presented today from Ash. You know, in terms of thinking about the things that we will do, reviewing our local strategy and partnerships. You know, again, we've lost a bit of emphasis in Gateshead, certainly, I'm not speaking for everybody, around our strategy and partnerships over the last few years with the pandemic. You know, actually we have the opportunity now to come together again and think about that multi-pronged approach to tobacco control, which obviously includes, importantly, stop smoking services as one aspect. We need to make sure that there's sufficient investment in stop smoking services to make sure that everybody has the opportunity to quit at every single opportunity that they come into contact with our services. So whether that's within general practice with a brief intervention, or whether that's within a more specialist stop smoking services, reaching into our midwifery, for example, supporting pregnant women to stop smoking. And I think that what we've been able to do, and really what we've been able to do because of our investment in Fresh over the last couple of decades, is free up a range of resources to allow us to target it more closely in our local area. And like I say, you know, the 12 local authorities continue to work collaboratively together to this day. So next slide, please. We've got a Tobacco Commissioners Network. Our OHID colleagues are instrumental in helping to bring this network together. It's chaired by a local consultant in public health from the North East, and, with deputy chairs, and has the commissioners from each of the North East local authority areas. And I think I really reflected on what Robert was saying early on about this opportunity to come together to drive up quality, but also where there are economies of scale. There are things that we can do better collectively together across the 12, which then means we've got more resource to do the targeted work that we need in our communities to address those inequalities that we've just heard Sharon talk about. But coming together regionally also gives you a much more powerful voice. And I remember back in 2007, when we were looking at the smoke-free public spaces, really being able to come together as a region and have a loud voice in that national debate around the things that needed to happen at a national level. And that opportunity to come together in that advocacy space, I think, is really important, because when you look at the progress that's been made on smoking prevalence, both for adults and indeed for children as well, that reduction has been marked and matched by regulation at a national level. So again, coming together and being able to work with ASH at a national level has given us that really great opportunity. So our commissioners network are now scoping out opportunities for collaboration, as I'm sure many of you are doing across the country, and proposals are currently being worked up through our ADPH North East group. And I'm just going to tell you a little bit about what's on the table for consideration now. Next slide, please. So in terms of local action, we really think that there's an opportunity for us to look at a regional collaboration that can support our local authority offer. Thinking about actually how do we maximise the uptake of stop smoking services in local areas, picking up on the point that was made earlier on by Corrina around the methods of quitting, and the fact that a significant number of our quitters, do this without our support. So actually, what can we do at a regional level to support that? Maximising the workforce impact. Again, Robert spoke about the importance of really good quality training, and actually being able to do that across the patch means that as staff move between local authority areas, whether that's within work or in their leisure activities, that they have the opportunities for the same quality of training across the patch. And then, of course, most importantly, understanding our success and impact, but also being able to think about equity and inequalities. And that builds on work that's been done across the North East, looking at health equity audits of our stop smoking service offer at a local level. Next slide, please. So potentially exploring a regional stop smoking offer. Like I say, we know that there are a number of unsupported quit attempts, as outlined in the ASH document that you've got. And actually, there may be an opportunity for us to think about how we can target those people who are making these quit attempts unsupported, but could do with that extra support. I think it was Sharon who said it isn't about people not being able to access the services or not wanting to quit. It's about them not being given the right level of support to quit. There's an opportunity through a smoke-free app, actually people who do want to quit in a more flexible way. What can we do there to make sure that that's maximised, that that's communicated, and that that's easily available to local people? And then, of course, regional insights-driven campaigns. Some of our most powerful work in the North East, I think, has been done by local people who have successfully quit. So if you want to Google Sue Mountain, she's a real local champion from South Tyneside who's had several cancer journeys and then managed to successfully quit. And she's been a real advocate for us at a national level in this space. Next slide, please. Workforce impact, I've spoken already a bit about this. It's really important that we get a quality training offer to our staff. We know that when these messages are delivered in a really, evidence-based way, that actually the impact is significant. So we need to ensure that we are providing that support, to the general workforce, to universal offers. Again, picking up on Sharon's presentation, how are we reaching into our social housing sector? But then also thinking about, more bespoke training. I noticed somebody had put in the chat that actually there was a significant smoking prevalence of people accessing for addiction support in drug treatments and alcohol treatment services. So actually, how can we ensure that those staff have access to that really good quality training? And then, of course, obviously, importantly, in collaboration with our NHS colleagues. Next slide, please. And then finally, measuring success, thinking about actually, I've already mentioned that a number of our local areas have already undertaken health equity audits to understand who are currently being reached, you know, with our services and who are currently being missed, so that there's an opportunity for us to do that targeted work in our local areas. And I think that this is the type of work that we can, you know, we can enhance it at a regional level, so that we can then use our local resources in a more effective way to target those communities in our local area. So final slide from me, and then I'll hand back over. Hopefully I've been quick enough. You know, we've got our next step is, you know, it's been a big piece of work that's been ongoing for several months now, you know, really excited about this opportunity. And I think we've got a real chance to make a difference, you know, engagement with each of our local authorities. And we've got an amazing public health registrar who's doing and leading that work for us, who's based in our OHID teams. So making sure that all local areas have the opportunities to feed in their ideas, their solutions, you know, and some of their, you know, the issues around what their local system looks like as well. So we can make sure that this works for each local authority area. Prioritisation within that tobacco control network, you know, again, that opportunity to come together and prioritise and rank the ideas and options based on maybe Robert's tool around evidence of effectiveness. And then, you know, a further collaboration through the task and finish groups, and obviously practicalities, including commissioning and procurement, because we know this is a challenge. But again, we've got history with this in the North East, and, you know, certainly my colleagues in Durham are responsible for commissioning the Fresh programme on our behalf at a regional level, and then thinking about that timeline and sequencing of actions, because we know that we need to be able to demonstrate the impact of the work that we're doing collectively together and how it's adding value to our local offer. Thank you.
Thank you so much, Alice. That was really, really helpful. So we're moving into our question and answer session now. The comment in the chat about smoking in pregnancy incentive scheme, I think was answered, but just to give a little bit more detail, the first part of that programme was about commissioning a delivery provider to develop national data and the voucher system. I understand that procurement activity is now almost complete, and once that's all finalised and signed off, there will be further engagement during May and June, initially with existing incentive services to explore the lessons and inform the programme going forwards, but look out for further information on that in May and June. There was a question in the chat, Corrina, I think during your session around clarifying whether the new funding can look at youth vaping. So, Corrina, I don't know if you want to respond to that one.
I think within the briefing paper, we're clear that the primary focus of the funding is around supporting people to quit. The evidence is lacking basically around the profile of what being addicted to vaping looks like, and indeed school-based intervention. So I think the ASH stance is really that this the opportunity with this £70 million of local authority funding should really be focused around supporting people to quit and on reducing harms from smoking specifically. Thanks.
Thank you. That was also my understanding. So it's not primarily targeted at youth vaping, it is around supporting smokers to quit. Are there any other questions that people particularly want to ask? Looking through the chat, I think we've probably answered most of them in the chat, but I don't know whether any of the speakers have spotted any that they wish to comment on or respond to. So there are various questions around the funding allocation to local authorities. So all local authorities will be receiving a grant, and the funding formula is available on gov.uk, which indicates, and yes, thank you for putting in the link there in the chat quicker than I could say it, and it's all in the letters which have gone out to local authorities. Look, I don't think, Corrina, you've come off
Yeah, I think there was an interesting question in the chat that I spotted around the choice of quitting method, and does it differ depending on sort of demography and socio-economic status. I'm not aware of sort of academic work in that area, but I can reach out to Sarah Jackson, or Robert and Sharon may know a lot better than me.
Sharon, do you want to?
Oh, Robert, no, you go first and I'll just chip in.
It's probably a little out of date now, but we did publish a study looking at variations in quitting method by various things like demographics. From my recollection, I don't think there was much variation in terms, once a person has decided to quit. There was, with regard to e-cigarettes or vapes, it certainly was the case that it was more affluent people who tended to use them, but that's now changed, and I think it's pretty much the same across the board, isn't it, Sharon?
Yeah, that's right. So in terms of groups with, multiple levels of disadvantage, we do see that vapes are more popular in terms of wanting to try them in a future quit attempt. There's been a few reports that have shown that. But while smoking is expensive and vapes are cheaper, they're cheaper once you start vaping. And this is where swap to stop is going to be really useful, because one of the things we've heard, and we've reported on this across a number of groups, is that if you're on universal credit, spending £25-30 on a startup kit for a vape is a big investment when you don't know if you're going to like it. It's different if you know you're going to like it, but if you don't, that's quite a big chunk of money. So we see that vapes are preferred for future quit attempts. And also, for somebody put in the chat about substance use services and quit rates, etc. Vapes fit in quite well in that environment because they're already used to offering harm reduction, so they get that language and they get what it's about. So staff are a little bit more amenable to talking about smoking when you talk about it in terms of harm reduction.
I was going to pick up that question, but you've covered it off well. Look, we're coming towards the end of our time anyway, so I'm just going to sum up now. And I think the key messages, as far as I'm concerned, are around the importance of basing our response in the evidence, and Robert's taken us through that, and there'll be materials that we can share after this with everybody to support you in that local implementation. I thought Sharon's message about going where people are was really powerful. I think we too often think about some of our marginalised communities as not accessing services, where it's in reality that our services aren't set up in a way that enable people to access them. So that was an important message. Investing in the workforce, I thought, Alice, your point about the point of investing in our people and having good training was very important, and also then measuring impact, which then of course will enable us to drive further improvements when we understand what is working. So that's a very quick summary of what's been a very rich hour, and a lot of content in there. I hope that you found it really helpful. It's been brilliant to see upwards of 200 people on this call, which I think demonstrates the interest that there is out in the system around this programme. Thank you once again to all our speakers. Thank you to Ash for setting this up, and have a great rest of your day. Thanks. Bye.